name is Mohamad Fakih. I'm from the United States. My passion is working on reducing catheter-associated urinary tract infection, and it's a pleasure for me to talk to you today. I'm going to discuss four main areas today. One is the urinary catheter risk and how to reduce inappropriate use. The second area I'm going to talk about is engaging healthcare workers to reduce that risk. The third one would be urine cultures, the inappropriate utilization of urine cultures in addition to the inappropriate antimicrobial use and the risk of resistance. And I will end my presentation talking about the optimal treatment for catheter-associated UTI. So when we look at urinary catheter utilization, about 20% of patients have a urinary catheter placed during their hospitalization. Many are placed either in the intensive care unit or when they come into the hospital in the emergency department, or if they're having surgery in the operating room. The presence of a urinary catheter does not just increase the risk of an infectious complication, but also mechanical or non-infectious complications. So to reduce that risk, the best thing is to just use the catheter when it's needed. So if we don't have a catheter, the risk is not there. So when we look at catheter-associated UTI, it's just a part of urinary catheter harm, and there are other associated areas where the urinary catheter can really lead to injury to the patients. And some are infectious, some are non-infectious, but just to share with you, urinary catheters increase the risk of immobility, so pressure also risk increases, and also there's potential of falls and deep venous thrombosis. Also, the catheter can lead to with the urethra and patient discomfort. And there's potential of increasing the length of stay of these patients, with the catheter in and not being discharged early enough. So it's a safety issue rather than just the infection related to the catheter. So how do we reduce that risk? If we look at this in four different areas, so if we know our catheter, when there's a need to use it, how to place it, how to maintain it, and then when to remove it when it's not needed, I think it'll help us quite a bit to reduce that risk. So let's start with when you need it, which is the appropriate indication. It is very important to clearly identify what the indications are and what they mean. So if you're working in one hospital, a very important first step is to sit down with the key leaders, review the literature, and have an agreement on what constitutes an appropriate indication. So you'll have institutional guidelines for placement. You incorporate appropriate indications into policies, competencies, and then you provide support to prevent unnecessary placement. And how do you provide that support to prevent unnecessary placement? You give the healthcare workers tools to reduce the risk of placing the catheter inappropriately. For example, if you have a bladder scanner, then you can tell if the patient has urinary retention or not. And if the bladder scanner does not show any urinary retention, then you don't need to put the catheter in. Giving patient urinals, condom catheters, providing skin care. So if there's a potential worry that the skin is getting injured because of incontinence, people would not inappropriately place the catheter and go through a route that can harm the patient rather than help. So what are the indications? And here, what you see on the screen are the CDC, the Center for Disease Prevention and Control at the United States guidelines from 2010. And they have them into different buckets. The first one is acute urinary retention or bladder outlet obstruction. Second one is the need for accurate measurements of urinary output in critically ill patients. So when we talk about critically ill, we think about the intensive care unit patients and the need for accurate measurements in that population. The third one is perioperative need, whether it's related to a urologic or a surgery or surgery close to urologic area. The second one would be for prolonged surgeries. And the third one, if you need a lot of fluids during surgery. And the fourth item within the perioperative is the need for intraoperative monitoring of urinary output. So another indication is also to assist healing of open sacral or perineal wounds in incontinent patients. And by this, we mean if you have a very large wound where a patient has incontinence and the incontinence is leading to further damage of that wound, then it will be an indication. Isolated incontinence does not reflect an indication. In fact, it's an inappropriate use of the urinary catheter. Another category is patients that require prolonged immobilization, and by that we mean patients that had trauma, and there's a risk if they move to have a further injury related to the trauma. So examples would be thoracic or lumbar spine injuries. And the last one is to improve comfort for end-of-life care if needed. And by that, if someone is on comfort care and if the catheter helps make them feel more comfortable, then it would be indicated. If the patient does not feel that the catheter is going to help, then they should not have that catheter. So how do we improve appropriate placement? And as I said to you, build first criteria for utilization in your hospital for the urinary catheter. What are the appropriate indications? Now, a lot of patients get admitted to the hospital from the emergency department. So the emergency department gets a lot of traffic of patients where a catheter will be placed. If you intervene there, then you have a very good chance to reduce the urinary catheter utilization, whether it's in the non-intensive care unit or the intensive care unit, in the whole hospital, because they go from the emergency department to many of these different units. And the way you do it is to engage two main stakeholders. One is the physicians and the other one is the nurses. And you have to work on both together. We tried to work with the physicians alone, and we found out that the nurses are a critical component for improving urinary catheter utilization in the emergency department. So work with both groups and let them engage each other to reduce the use. And we had a pilot of 18 emergency departments at Ascension Health, which is the system I work at. And these hospitals ranged from small to very large tertiary care centers. And we're able to reduce the placement by about a third. And what we noticed is that those hospitals that have the higher baseline for utilization benefited more than others. So here's what you can see. The baseline was about 9% utilization in the emergency department. With the intervention went down to about 6%, and with sustainability, which is, the whole study was about 6 months. The sustainability period dropped to 5.4%. So pretty strong reduction in utilization. And what we noticed also that the appropriate reason for placement has improved with time. So that's another very important factor that the adoption happened at these emergency departments. So we talked about, knowing what the indications are. Now, how do we do the proper insertion? The main thing for proper insertion is to have all the elements that you need for the insertion in one kit. That's why I have it in red. Have them all in one kit. Make sure that the steps then for insertion and keeping it in aseptic technique are complied with. So from hand hygiene to aseptic technique and use of sterile equipment. Using the appropriate catheter size is important. The smaller the catheter, the less risk for trauma. And what you can do is work on competencies for the healthcare workers to ensure that this is done well. The third area is the maintenance and knowing how to care for a urinary catheter. A key factor there is to have a closed urinary drainage system. And by that, I mean that you do not open the closed urinary drainage system. So where you have the urinary catheter and the tube that's connected, you do not disconnect them from each other. And as you see from the picture, the red cover is on purpose there to ensure that the urinary catheter system was not disrupted. So you can check if you have that type of urinary catheter, you can check whether it was disrupted or not. Other elements would be unobstructed urinary flow, no kinks, the urinary bag being below the bladder so it drains, and the device being secured so reduce the risk for trauma to your urethra. So we talked about the first three components. One is identify the indications. The second one is to have proper insertion technique. The third one is proper maintenance, and the last one is to remove the catheter as soon as you do not need it. So that's a very important component, because the longer you keep the catheter, the higher the chance to develop bacteriuria, and then when you have bacteriuria, you have the risk of developing symptomatic urinary tract infection. So know when it's no longer needed. I can share with you studies we've done, and this was a study in 2006 we've done where there was a nurse champion who rounded with other nurses in multidisciplinary rounds across the whole hospital. And it was an incredible success where we were able to reduce unnecessary urinary catheterization by about 45%. Another study we done in state of Michigan where we had 163 units, and very similar to what we've done at St. John Hospital Medical Center, the first pilot study, and we had a reduction of 25% in use of urinary catheters, total reduction, which was also very impressive. And the key factor is to have someone responsible for the work, to make sure that there's someone who's looking at these catheters every day and evaluating whether they are needed or not. So daily evaluation for need is key. And then what's also important is to provide feedback on performance. So if I'm a nurse, I'm a clinician, and I don't know that I'm using way more catheters than what I need to, then I will continue doing the same thing. But if I get the numbers and I'm compared to others that are similar to me, then I'll know that I'm different or I'm using more, and there's much more of an urge for me to focus more on that issue and reduce unnecessary use. On the Cusp Stop CAUTI is a very large initiative, is a 50-state, so national initiative in the United States, where about 1,300 hospitals were included over 4 years. We published cohorts 1 through 4 last year, about 926 units, and at that point, what was very striking is that we were able to reduce urinary catheter utilization in the non-intensive care units, in addition to a reduction in catheter-associated UTI, which was about a third. But the intensive care unit, there was no change. And that tells us that the intensive care unit is quite special in the way they look at the indications and whether the need is there or not. It's much tougher because if you remember the indications, CDC indications, it includes utilization of urinary catheters in critically ill if you need to monitor urine. But the key there is in the ICU is what is considered an important thing to monitor as far as the urine monitoring. And another key component with the ICU is that a lot of people that are intubated may not need urinary output monitoring, but it is quite tough for the nursing care to happen without the catheter, so that's another barrier. So I can tell you the cohort 1 through 9, with that study, the whole cohort, not just 1 through 4, had a similar result from 1 to 4. So the catheter-associated UTI rate decreased by about 30% in the non-intensive care unit, but not in the ICU. ICU, no change. And if you look at the population-based CAUTI rate, it decreased even higher. It's about 36%. So this is if you use patient days instead of catheter days. So again, this is the On the Cusp Stop CAUTI paper published in New England Journal of Medicine last year. And the key components were conducting daily assessment of the presence and need for an indwelling urinary catheter, avoiding the use of an indwelling urinary catheter by considering alternative urine collection methods, and emphasizing the importance of aseptic technique during catheter insertion and proper maintenance after insertion. Additional areas that were also important were providing feedback on performance, as far as the process, which is the catheter use, and as far as the catheter-associated UTI rates for these units, and addressing any gaps in knowledge related to urinary catheter management processes. So what we've seen again is a reduction in non-ICU utilization, but this was not seen in the intensive care unit. So we talked about the 4 main areas that you focus on to reduce the unnecessary catheter use, but you cannot do it if you just do it in part of the hospital, because the hospital is connected and patients move from one side to another. So you have to consider this as a multidisciplinary and a multi-departmental work. By multi-departmental, it may be different types of units. Multidisciplinary, it's different clinicians. And I'm going to talk a little bit more about how to engage the healthcare workers. But here from this slide, you can see the emergency department, the intervention, the intensive care unit, and the floor. And when we talk about the intensive care unit, you think about this area as an area where you have a high utilization of urinary catheters, and you go into another area, which is non-intensive care unit, lower utilization or lower prevalence of urinary catheter use. It's a great opportunity to discontinue these catheters before they leave the intensive care units. So how do we engage the healthcare workers? We worked quite a bit with champions, someone who is very passionate to push that work, and someone who brings accountability to the work. But these champions cannot work on their own. They need supporting disciplines. And you have to make the case for these supporting disciplines on why they will support your work. And I will share with you what I mean by that. The supporters can be clinicians, which we almost always focus on, but the other important factors are the leaders. So I'm talking about administrative leaders in the hospital, even clinician leaders, such as chief medical officers. Patients are important, and we have not really focused as much on them. I think patient empowerment and letting the patient ask whether the catheter is needed before it's placed is an important factor that we should look more and more to in the future. And I think all these supporters can lead to better outcomes for our patients. So the supporters can facilitate the champions' work. They point out any barriers or concerns. And these are important because if you talk to someone and you say, well, please help me out with a certain initiative, and if there are certain barriers or certain concerns that these clinicians have and they're not addressed, they will not be on your side. So think about these supporters as, getting your input, but at the same time giving you feedback so you can improve your process when you're doing the work. And they will help build capacity capacity to sustain the effort. So goal alignment is very critical, and the way you push for goal alignment is to clear any issues that these clinicians have to adopt what you're asking them to do. So this is the supporters, and I'll give you a couple examples. So for a urologist, if you tell the urologist, I'm worried about catheter-associated UTI, the urologist is not going to be as much of a supporter. But if you can talk to the urologist and say, these catheters end up causing hematuria, injury to the bladder, these are much more meaningful for that urologist because these are issues that he or she will not really like to deal with, and they feel that these are preventable. A geriatrician knows that the catheter does not only cause infection and can get the patient into big trouble, but also can reduce mobility. And in frail patients, it can lead to bad outcomes. So link the reason why they will help you, and so on. So you look at others like hospital medicine. If you have a hospitalist, they want to get the patient better soon. They want to get them out of the hospital as soon as they're able to, and having more devices is not going to help. So if you look at each discipline, see what's in common between your goals and their goals, and push for that goal alignment. This is an example from St. John Hospital Medical Center in Detroit. And that hospital is the first hospital that did the pilot work on catheter-associated UTI with the nurse-driven removal of unnecessary catheters. And if you've seen over the years, we pushed for more and more intervention, and we added more and more units to be part of the work. One thing I can share with you is that we incorporated on 2 days a week, the units would send to the infection control team device utilization data on Tuesdays and Thursdays, and it was the responsibility of the case managers. And what was very interesting is that this did not just push for people to look through multidisciplinary rounds, but people always knew that someone is watching, someone is following up on the numbers. And we did it over about 10 years. And as you see, the utilization in non-ICU dropped from about 18% to about 12 to 13%, and it's still continuously dropping. So huge improvements over time, and these interventions showed sustainment. So we surveyed also the nurses and asked them, who is on the unit responsible for urinary catheter need? And overwhelmingly, the nurse caring for the patient was the one who is responsible. So either by himself or by herself or with others. But overwhelmingly, the nurse was identified as the responsible person. And daily evaluation was more than 90% in their opinion that should be done daily, and vast majority all shifts. So it was considered as part of the patient care. And they were very happy with multidisciplinary rounds, pushing for catheter removal, and they were very confident in their knowledge about the indications. So you see the adoption was really strong in that hospital where they had the successful results. So I did talk to you about, the four areas about the indications, how to place the catheter, how to maintain it, when to remove it. I talked to you about the healthcare worker engagement. And the next thing I'm going to talk to you about today is, asymptomatic bacteriuria and how it affects antimicrobial stewardship. So when we look at the urinary catheter, we focused on catheter-associated UTI, but it's a very small part of the issue. When you look at other areas that are associated with bad outcomes, with catheter-associated UTI, sometimes you may get bacteremia, and then this can seed certain areas of the body and can lead to bad outcomes. The other thing is, and this is the biggest group, is asymptomatic urinary colonization. So you have asymptomatic bacteriuria. Well, the problem with that, whenever it's identified, physicians tend to treat asymptomatic bacteriuria inappropriately with antibiotics. And that will lead to either resistance or Clostridium difficile infection, or other side effects that may not be infectious, but maybe a drug reaction. So that's a very important area that has not been focused on as much as we should. But I see it as a very big harm related to the catheter. And that's why I did not want us to think that catheter-associated UTI is the main area. I think there are other infectious complications, such as inappropriate treatment for asymptomatic bacteriuria that lead to bad outcomes. So let's talk a little bit about it. Inappropriate culturing and antibiotics. So multiple studies have shown that catheter-associated bacteriuria is often misdiagnosed as catheter-associated UTI. So people give antibiotics for asymptomatic bacteriuria. And clinicians even will give you antibiotics even if they know that the patient has had Clostridium difficile infection before. So it does not stop the physicians from giving antibiotics, which is a worse thing for the patient, because they will have recurrence of disease and potentially risk of mortality, a risk of further harm. Another thing that's very interesting is that whenever someone has fever, it is likely they're going to get a urine culture. And then even if they have an alternative source, they that the source is something else, they would tend to treat that bacteriuria. Female, gender, elderly, pyuria, having pyuria as a part of the UA, hematuria, positive nitrites on urinalysis, all of them increase the risk of inappropriate treatment with antibiotics. To add more, if you look at the difference between hospitals, some hospitals have more tendency to treat much more asymptomatic bacteriuria than others. So there's a cultural thing, how people treat, how clinicians treat in a hospital affects utilization of antibiotics for asymptomatic bacteriuria. So we talked about how asymptomatic bacteriuria will lead to inappropriate antibiotic use. Now I'm going to share with you, this is from the MMWR Mortality Morbidity World Report in 2013, and where they looked at emerging infections program in 3 states. They had 72 carbapenem-resistant Enterobacteriaceae, and they found out that the urine was the most common source for these organisms, about 90%. Excuse me. And the presence of the urinary catheter within past 2 days was about half of them. So there's an association between the urinary catheter and resistance. And it may be that it's a reflection of maybe sicker patients, or maybe when you have the urinary catheter, people are getting way more antibiotics for asymptomatic bacteriuria and increasing their risk for resistant organisms. So the last part that I'm going to talk about is catheter-associated UTI, its definition, and how it's treated. So if I ask you, how do you define catheter-associated UTI, I think everyone will define it differently. Now, we have 3 main areas where we can define it. One is a clinical definition, the other one is surveillance definition, and the third one is coding definition, so how it's billed in the hospital. And they often change, and they may underestimate the infectious risks. So we talk about infection. Is it having bacteria in the urine? Is it having symptomatic urinary tract infection? How do you define it? Well, the main definition I think that is accepted is the clinical one, although in the United States we have been using the NHSN, the National Healthcare Safety Network definition, as the main definition for public reporting. If we look at the clinical definition, it says bacteriuria more than 1,000 colony-forming units and signs or symptoms of a urinary tract infection and no other identified source of infection. And you have to have the catheter, and it's a clinical diagnosis. So this is how we define distinguish between the asymptomatic bacteriuria and the catheter-associated UTI. It's not an easy diagnosis because it's by exclusion, and it's also independent of pyuria. So for the longest time, physicians looked at pyuria, how many white cells they have in the urine, and they said, okay, there's a lot of white cells in the urine with someone who has a catheter, so this means it's a UTI, which is really not true. So I'll talk to you a little bit more about the clinical definition, because I think this is the main one that physicians look at. And let me read how it's defined. This is from the IDSA, Infectious Disease Society of America guidelines in 2010. Signs and symptoms compatible with catheter-associated UTI include a new onset or worsening of fever, rigors, altered mental status, malaise, or lethargy with no other identified cause, flank pain, costovertebral angle tenderness, acute hematuria, pelvic discomfort, and in those whose catheters have been removed, dysuria, urgent or frequent urination, or suprapubic pain or tenderness. So it is a diagnosis by exclusion, and that's the tough part with catheter-associated UTI. The only time where you do cultures in asymptomatic patients, so look, and you have asymptomatic bacteriuria and you treat, is for pregnancy, before surgery in 2 areas, either before transurethral resection of the prostate or a urologic procedure where you expect mucosal bleeding to happen. So it's very important to only order urine cultures when you're suspecting catheter-associated UTI. And you have to remember, the urine may not be sterile. So this is the the main thing that you have to remember. The older we get, we start having a higher risk of having bacteria in our urine. And these bacteria live with us symbiotically, and the vast majority of time, they're not causing illness to us. So we should not be treating asymptomatic bacteriuria. And you have to think diabetics, elderly patients have a higher incidence. And these are the patients that usually we abuse the most antibiotics because of treating asymptomatic bacteriuria. So just remember that each population has a different risk as far as bacteriuria, but it doesn't mean if they have bacteriuria, we have to treat with antibiotics. So again, from the IDSA recommendations, in the catheterized patient, pyuria is not diagnostic of catheter-associated bacteriuria or catheter-associated UTI. So if you do a UA and you're looking for protein or you're looking for blood in the UA because of renal insufficiency and you find white cells, don't do urine culture unless they are symptoms suggestive or signs and symptoms suggestive of a urinary tract infection. The presence, absence, or degree of pyuria should not be used to differentiate catheter-associated asymptomatic bacteriuria or catheter-associated urinary tract infection. Pyuria accompanying catheter-associated asymptomatic bacteriuria should not be interpreted as an indication for antimicrobial treatment. And finally, the absence of pyuria in symptomatic patients suggests a diagnosis that is not catheter-associated UTI. So this is very important. So if you do a urine analysis and you're suspecting urinary tract infection and the urine analysis does not show any white cells, you don't have to do urine culture. But if you do a urine analysis and shows white cells, it does not mean that the patient has UTI. It's not going to help you much. And what will help you is the clinical symptoms. And then this should be the basis on how you will figure out if that patient has a UTI or not. The urine color or odor of the urine does not help identify if the patient has a catheter-associated UTI or not. So these should not be used to differentiate between asymptomatic bacteriuria and catheter-associated UTI. So what we have written recently is some advice on how to address the clinician practice and address the process for testing, because I think it's very important to address when to test, when to do the urine cultures. If the urine cultures is out and there is bacteriuria, it's much harder to push back with the physicians on not doing urine cultures. So when is it appropriate to do urine cultures? One would be part of an evaluation for sepsis without a clear source. So if you have someone who has sepsis and you have you're very clear that the patient is in respiratory distress, they have a big pneumonia, there's no reason for us to do urine culture. Versus if there's no clear source for sepsis, then absolutely, a urine culture would be, the right thing to do. Based on local findings suggestive of catheter-associated UTI. So if they have a clinical finding suggestive of a urinary tract infection, then also order the urine culture. When we looked at this in different studies, it's rarely seen in patients that have a catheter-associated UTI. And prior to urologic surgeries where mucosal bleeding is anticipated, and I talked about this, so this is to screen, and in early pregnancy. And in those situations, you want to avoid urinary catheters if possible. So what about the treatment of catheter-associated UTI? Based on the guidelines, antibiotics for 7 days in patients with prompt symptom resolution. So fever goes away within 72 hours, and 10 to 14 days in those that have delayed response, regardless whether the catheter is still present or is removed. Now, in a specific population where the patients have very mild symptoms and the catheter is removed, a 3-day course is sufficient. And you should always evaluate if the catheter can be removed anytime you're seeing the patient. So if you're suspecting UTI, think first, can we remove that catheter? And finally, I want to just remind you that catheter-associated UTI is part of a much bigger problem with urinary catheter harm. And if we just focus on the catheter-associated UTI, we will really be giving a disservice to the topic of urinary catheter harm. So think about it as an infectious complications and non-infectious complications. Part of the infectious complications are catheter-associated UTI, and a big part is asymptomatic bacteriuria associated with inappropriate antimicrobial use. So if you have antimicrobial stewardship teams, I think it will be a great partnership between dose infection prevention and antimicrobial stewardship to address this issue, and then address with other key leaders the non-infectious complications to get more people on board to help you reduce that harm to the patients. And thank you very much for listening.